in a situation where the cancer is advanced. It's already stage 2 or 3 or even stage 4, where the cancer has spread beyond the ovary and it's involving some of the intestine, maybe the surface of the liver, the spleen. And in those situations, a patient usually has cancerous fluid called ascites in the belly, and her symptoms are vague GI symptoms, maybe some irregular bowel movements, some pelvic pressure. Classically, her pants don't fit because the fluid is accumulating and she's not exactly sure what's going on, and perhaps a general surgeon or an OB/GYN will take the patient to the operating room, not realizing that they're dealing with an advanced ovarian cancer. They'll find that there's cancer diffusely spread throughout the abdomen, and they'll do what's called an open and close. They'll open the belly, find the cancer all over, and then they'll just take a biopsy of some cancerous tissue, send it to the lab to confirm what kind of cancer is, and they'll close. That's a surgical procedure that is not necessarily what a gynecologic oncologist faced with a similar clinical scenario would do. What we would do in situations where we think we can get all the cancer out, we would do a big incision, and we would try and take out the cancer wherever it's spread, whether it be on the ovaries only, or the liver, the spleen, the diaphragm. In a safe way, we would try to take out all the cancer, and that's called a debulking or a cytoreduction operation. So an optimal debulking, first we have to explain how somebody with ovarian cancer, how their abdomen looks. People kind of think that you just go in there and then you just pluck apples from the apple tree. And even if there's 100 apples, how hard could that be? The problem is it's really not apples from an apple tree. You have to kind of picture, let's say I had a bucket of sand, and each little sand granule represents a cancerous mass. And it's as if somebody took a bucket of sand and kind of spilled it into the abdomen. And so those sand granules could go anywhere. They could all clump in the pelvis, and almost all the tumor would be in the pelvis, or they could all clump near the liver and the right diaphragm. Or most likely, as in most cases, with the fluid in the belly, the sand particles would wash around the entire belly, and the operation to take all that out could take hours, to take out every little granule of sand. And sometimes we're not able to take out every single granule of sand. But studies have shown that if we're able to take out all the particles to the point where you're left with little tiny tumor nodules that are of a certain dimension, that those patients will do better. They will have a better response to chemotherapy, their remission will last longer, and their chances of cure will be greater, and their overall survival will be greater. In optimal debulking, the most strict definition is that we remove every single particle of sand, every single tumor nodule. Sometimes that can't be done, but even when you can't take out every single particle of sand, if you can get out almost everything and leave very, very small amounts of little, what we call residual disease, that is an optimal debulking.